this one was definitely on a dramatic side. This came in February, and the history here was that we had a mother in her mid-30s who presented symptomatically. This wasn't a screening study, but she came in symptomatically, and her history was that when she was picking her 3-year-old up, he would tend to throw his head backwards and effectively headbutt her, you know, in her breast. And this occurred several times, and the patient was experiencing some swelling in this area. So the clinician sent her to us with the pretty, you know, defined clinical question of, you know, is there an underlying mass that's accounting for what we're feeling here, or is this simply swelling, you know, that was a consequence of the repetitive but low-level trauma that the infant was causing, you know, by headbutting the mom. She'd had a previous palpable area on the left side several years before we saw her, which was not significant. And the point I want to make here, too, with this case is going into this case, as this patient presents to the hospital, she comes with a bias that I definitely had when I was looking at the case, and that's that I got an explanation for this that was secondary to, you know, what happened to her clinically and consistent with her history. So this gives me a bias. And also, anything I find along those lines, diffuse swelling or anything like that, are going to plug into a satisfaction of search possible error. So what I found here was that despite the bias and the satisfaction of search potential problems I had going into the case, the algorithm kept me on track for another possibility. So let's go to the next slide. All right, so we had a prior in 2016, and we have comparative images here on the left from February of this year and from 2016. So on ultrasound, there wasn't anything focal. There was diffuse edema and kind of diffuse swelling laterally in the right breast. Again, that was not unexpected given her history. The patient, she reported it and said she thought it might be getting a little better. On the mammogram, there's kind of a diffuse increase in parenchymal densities and asymmetries on the right-hand side, and specifically you can see two there that we marked with the arrows. But with spot compression and additional ultrasound, we didn't see anything focal, and all those areas just kind of went away, and it was fairly diffuse. Next slide. So again, this is February on the left and the prior on the right side, and those asymmetries we're trying to mark again. But again, it's kind of a spotty, scattered change, not inconsistent with post-trauma edema. The orange arrow is the palpable region, which really isn't, you know, in that view showing anything too specific. And now the next slide. So here's some of our scores. So in addition to the high risk score, we're getting detection scores that are in the 90s. Now this is very concerning. Basically, when you have scores of this level, you are very suspicious for an underlying malignancy. So you get pretty aggressive here. There were some scattered calcifications, nothing really grouped, nothing again focal on the ultrasound or the additional imaging that we did. So next slide, you can see the detections there with their individual marks. An example of what this looked like with our additional compression and such, everything just kind of blended in with everything else. We didn't have a target. Next slide. So again, you get these scores. So I've got a reason for all these findings, that there's trauma. The findings aren't not consistent, but this K-score is definitely highly elevated in somebody of this age, very concerning. And on top of it, I have an elevated risk score, which, you know, according to Michael's article, is highly correlated, especially with the aggressive cancers. In his paper, they picked up 76% of the grade 2 and grade 3 lesions in their group with risk. So what you're seeing here is potentially the real sweet spot for risk, and that's in younger patients who shouldn't have high risk scores much at all. And also, they tend to get the most aggressive cancers. So this case had a real potential here. It's either trauma and I send her home and don't worry about it, or this is a very early aggressive cancer that really could cause a lot of problems. Now, if I didn't have Profound, if I didn't have the suite of tools and the algorithms, there's a good chance I would have sent this patient home and just, said, we'll follow you clinically. I had an explanation for the findings. But that proved not to be what we did due to risk. And fortunately for us, that was the path we followed. So next slide. So again, everything's kind of, looking the same and pressing out. Next slide. So what do we do with this? There was really nothing to target for stereo, nothing for ultrasound, even though I had a high level suspicion. I did not like that elevated risk score at all. We discussed MRI. Given our backlog, we were probably looking at 4 to 6 weeks before we got it done, and anything subsequent to that. Again, the history wasn't inconsistent. So after discussing everything with the patient quite a bit, we decided that we would bring her back in 12 weeks and see if this was resolving, which is what it should have done if it were trauma. Now in this case, it didn't resolve at all. And you can see with the blue arrow here on the right side. Now this is 3 months into our workup. This is 3 months after she presented in February with the findings that I initially discussed. But now you see this lesion here has definitely progressed in the interval. Now with spiculated margins, architectural distortion. And you can go to the next slide. And again, we're seeing, 3 months later, a form target now on the mammogram images. So when we saw this interval change, obviously not happy about it, but super thankful we didn't send this patient home and just write this all off to trauma, because this really could have been a really significant case. All breast cancers significant, obviously, but when it affects a mom with a young family, it's the worst scenario you can think of. So again, I think there's huge potential for risk to play out as really a strong tool for this group of patients who still, at this point in the game, we're seeing 45, we see half the morbidity in breast cancer cases in women 45 or younger. So definitely room to apply this in that age group. So next slide. Again, this is when we brought her back. We're showing a progression, a definite target now. We took her to biopsy the same day. Next slide. Okay, that was the target we eventually picked. On the CC view, you can see on the right-hand image that there's a top hat localization clip next to this focal asymmetry, which measured, all of 6 millimeters. So it wasn't that big, but you can see how this grew in 12 weeks. So this was scary to see that change. Next slide. Okay, so I think that this is one of the scariest cases you'll see come across your board. These are the types of things that you just hate to even risk making the wrong decision on. So, with this presentation of trauma, it looked like we had an explanation, but the detection scores were very high, the case score was very high, and the risk score was very high in a woman in her 30s. So, when given the experience that we've got in this now, if that comes across, this is super concerning. And what you do next, that tends to be kind of a hold up sometimes for embracing risk, not knowing exactly what to do next. But in this case, bring her back early, doing MRI, you can do something. And in older patients especially, Options as simple as making sure they comply with their follow-up mammogram might make all the difference. Because as Axel showed again, some of those cancers they're not that fast growing. Some take a while, and just coming in when you're supposed to might be the biggest benefit of using the risk to help you make your decisions. So again, with Michael's paper, showing 20 times increase in breast cancer in these high-risk patients, showing that their cohort picked up 59% of the cancers that were detected versus 24 for TC8. I just think there's a super compelling argument to incorporate risk along with the detection, which again, 94% of lesions, that's super high. And the case scores, those are very helpful, especially when they're above 60, especially when they're in the 80s or 90s. But then to have the risk metric in there too, I believe is something that is going to save a lot of lives going forward. So I think that's all I have on that case, and I'd be able to turn it over to Angela at this point. Here's the final follow-up, and of course, this did come back as a high-grade cancer. We had macro-metastatic disease in the nodes, and also we had quite a bit of lymphatic invasion associated with the tumor as a grade 3, ER/PR positive, or ER negative, PR HER positive. So, again, for this patient, I really think I know that the tools that I had with Profound really helped me give this woman a chance and her family a chance. So, wanting to be the best I can be, I really don't think I would ever practice without these tools going forward. And I think this case is one that really will never leave my mind as how much of an impact this can make. So